Hello everyone, I am Dr. Nisha Garg'S and I welcome you all to the orthodontics classroom of Dr. Nisha Garg'S Dental Academy. So today we are going to discuss some very interesting image-based questions. These questions are very common nowadays in the exams, and these questions are directly picked up from the book Profit. So let's begin. So this is the first question. The question comes like this: that identify the red lines which are shown in the picture here. So you need to identify these red lines which are there in both the maxillary and the mandibular arch. So let's see what is the answer to this question. So these red lines are basically the lines of occlusion. Now this concept of line of occlusion was given by Angle. Now according to him, the line of occlusion is a smooth catenary curve passing through the central fossa of each upper molar and across the cingulum of upper canine and the incisor teeth. So basically it goes through the central fossa in the posterior segment and from the cingulum region in the interior segment. Then if we see in the mandibular arch, the same line runs along the buccal cusp and the incisal edges of the lower teeth. Thus, it specifies the occlusal as well as the inter-arch relationship once the molar position is established. So, according to Angle, both these lines of occlusion, the maxillary line of occlusion and the mandibular line of occlusion, when we close our mouth in the case of maximum intercuspation, they should lie one over other. They should be same. As you can see in this picture also, they are lying one over another. So these lines basically specify the kind in which the teeth has to be arranged. Now if we see the occlusion, the buccal cusp of the mandibular posteriors, they articulate in the central fossa of maxillary posteriors. So these lines should coincide when we close our mouth. So that's the basis of this line. Again, if you see in the interior region, the lines pass through the incisal edges. But in case of maxillary interior, the line passes through the cingulum region. So basically here also the interior portion of the mandibular arch, the incisal edges of interior in the mandibular arch, they coincide in the cingulum area of the maxillary arch. So these lines, when they coincide, they give us the best occlusion which should be there, which is stable, functional, and it is aesthetic. So these are the three things which we see: the occlusion is stable, it is functional, and it is aesthetic. So this picture is a line of occlusion, and the concept was given by Angle, who is the father of orthodontics. Coming on to the next slide. Now the question here asked us that what kind of index is being depicted in the picture here, or what is being measured in the picture here. So if you can see, we have a mandibular arch, the incisors, they are crowded, and we are measuring the distance between the contact points. So this is basically the Little's irregularity index or incisor irregularity index. So incisor irregularity usually is expressed as the irregularity index, and this was given by Little. So it is known as Little's irregularity index. So what we measure here is the total of the millimeter distance from the contact point on each incisor tooth to the contact point that it should touch. So if you can see here, this contact point should have been present here. So what we measure is the distance between these two contact points. So this distance is then added, and then we calculate the total irregularity index. So as shown by these blue lines, we measure the distance between the contact points. So this gives us the Little's irregularity index. So this is used to know that how much your incisors are crowded, how much your incisors are irregular. See here, if the sum is more, for example, if we say here the sum is 15 millimeters, then we know that yes, there is a lot of crowding in the mandibular arch. If we say the sum is just 5 millimeters, okay, then we can say that it's a mild to moderate crowding case. So that is how Little's irregularity index help us to quantify the case. So these images are of Little's irregularity index. Moving on to the next slide. Now the question asked from this picture is that what kind of malocclusion could be possibly seen in this case, where we can see that there are frequent fractures of the anterior segment. As you can see here, there is fracture to the anterior teeth, and this is seen in some kind of malocclusion. So let's see what it is. Now here what we are seeing is a fractured maxillary center incisor of a 10-year girl. Now there is almost 1 chance in 3 of an injury to a protruding incisor. As we can see here, what we can see is only maxillary interiors are proclined. Okay, only maxillary interiors are proclined or protruded, as we say. Thus what we can see is that almost there is 33% chance of fracture. It is 33% chance that this can fracture. So these are most commonly seen in class 2 div 1 malocclusion. Seen in class 2 div 1 malocclusion. So what are the features of class 2 div 1 malocclusion? That there is proclination or protrusion of the maxillary interiors, while mandibular interiors are generally in their normal alignment, or there might be slight proclination of the mandibular interiors also. There is an increase in overjet. Now due to this, the maxillary interiors, they are kind of unsupported and they are lying much interiorly, due to which whenever there will be a trauma, they will be the first teeth to contact, and hence it is very common that they will get fractured. So this kind of presentation is very common in class 2 div 1 malocclusion. So moving on to the next slide. So the question asked from this picture, it's a very classical picture, that what kind of gradient is being shown in this picture. There is a gradient that is being depicted and we have to name the gradient. So let's see what is the answer to this question. So this is basically schematic representation of the cephalocortal gradient of growth. It is known as cephalocortal gradient of growth. So let's see what is cephalocortal gradient of growth. Now schematic representation of the changes in overall body proportions during normal growth and development. So this is basically depicting the change in body proportions that occur with the normal growth and development. So after the 3rd month of fetal life, the proportion of total body size contributed by head and face steadily declines. Now as we can see in the first picture, now almost the head and the face, they make almost 50% of the body. Right, you can see here they make approximately 50% of the body. As we grow, the proportion of the caudal part, now this is the cephalic part and this is the caudal part. As we grow, the proportion of the caudal part goes on increasing and the proportion of the cephalic part goes on decreasing. As you can see here also, we are reduced to about 25%. Here the proportion was 50% and here in this picture we have reduced to about 25%. So this gradient is known as cephalocortal gradient of growth. That is, as we move towards the feet, part, what we can see is that there is increased gradient of growth. Now if we can see in these diagrams also, if we see the hind limbs, now these here, they constitute even less than 25%. But when the growth is complete, we can see in this diagram that their proportion increases to approximately 50% of the body. So as we move down towards the feet, there is an increasing gradient of growth. Now this gradient is known as cephalocortal gradient. Again, A similar thing can also be seen in the skull. If we see, this is the maxillary part, the mandibular part, and this is the cranium part, and this is the facial bones. Now if we can see here, the cranium is large. The proportion of cranium is very big when the growth is starting, but as the growth proceeds, what we can see is the proportion of the cranium is decreasing while the proportion of the facial bone it is increasing. So here also what we can see is cephalocortal gradient of growth. Another important thing which we see here is that the growth cessation also takes place in the cranial region first. Now we all know that the brain development occurs at a very early age. So approximately at about 5 to 6 years of age, majority of the brain development is completed. Why again? Why? Because we have cephalocortal gradient of growth. So as we move toward feet, there is first of all increased gradient of growth. Another thing is the growth will continue to a longer duration as we move towards the feet. So this is cephalocortal gradient of growth. Let's move on to the next slide. So here what we can see in this picture is, we can see that there is staining of the teeth. Here what we can see is that there is staining of teeth. So the question which was asked to us, that what kind of staining is present in this picture in a patient who has been taken medication for respiratory illness. So let's check what the staining is. So this is basically a tetracycline staining. So this is tetracycline staining in the teeth of a boy who received large doses of tetracycline because of repeated upper respiratory infection in early childhood. Now from the location of the staining, it is apparent that tetracycline was not administered in infancy. Why? Because here we can see that there is no staining on the incisal region, while we can see staining near the cervical regions. So the large doses were given when the crowns of central incisor were about half formed, or approximately at 30 months of age. So here what we can see is, since the incisal edges, these are not affected by the staining, so we can say it that the tetracycline was begun when the central incisor crowns were about half formed, as we cannot see any staining on the incisal region and it is only seen in the cervical region. So what we can judge by this is the approximate age by which the tetracycline was started. So this also helps us to elicit a good history of the patient, that what was the approximate age at which the tetracycline was started, that it was about 30 months. Why? Because the incisor edges, they are completely fine while the cervical region is affected here. Then what we can see is the canine, it is completely normal, and also other posterior teeth, they are approximately completely normal. So after a few months the tetracycline must have been stopped. So by this we can know that approximately at what age large doses of tetracycline was given. So this is how the tetracycline staining looks like. Okay, let's move to the next slide. A beautiful appliance which has been placed. So the question which is asked in that, what kind of appliance has been placed in this patient? Now it's a technique which is used commonly nowadays. It was not used much in the past, but yes, it has become a common finding nowadays. But the technique has been modified and we'll just talk about it after seeing the answer. So this is basically external fixation for lengthening of mandible by distraction osteogenesis. So this technique is distraction osteogenesis. So let's study a bit more about this technique. What we do here is, Whenever we have a bone which is very small, we fracture the bone first of all. Then what we do is we let the formation of callus to happen. The callus will be formed. The callus is basically not mineralized, so it's a soft tissue. What we'll do is we'll put this kind of fixation appliances. They will help to expand the callus. So if the callus here is 1 millimeter, after distraction maybe it will become approximately 10 millimeter. Now after that what will happen is that 10 millimeter of callus will ossify and will help us to form a 10 millimeter of new bone. So what we have done here is that we have increased the length of the bone. So here it has been done in a child with severe asymmetric mandibular deficiency. As you can see here, there is a severe deficiency of mandible secondary to injury at an early age. So these kind of cases generally occur when there is injury to the condylar area. Now if the patient has any injury to the chin or to any other area of mandible, then there can be condylar fractures. Now these fractures lead to deficiency of growth on one side. Right, if you can see here, there is deficiency of growth on one side. So what we do is we use distraction osteogenesis to increase the bone. Now here we are using external fixation. As you can see, the appliance is external. Now these leave scars on the face, so that is not a good thing to have. Hence what we do is we nowadays use internal fixation. Now these are intraoral appliances that we use. So nowadays we use internal fixation first of all, and then these are the devices for distraction osteogenesis. Now let's study a bit more about it, that why and how it is required. Now see, this is a case. Now this case here has a very small mandible. It's a very small mandible. Now even if I wait for 18 years for the gross cessation to occur and then do a surgery for this patient, now I cannot lengthen the mandible too much. Why? Because what we do in surgery is we cut the mandible sagittally. Now if this is the mandible, now this is the condylar process, the coronoid process. What we do is we cut the mandible approximately here. We move this segment in front, and what we do is we put bone plates between those two segments. Now if we have to do such kind of procedure in this case, what will happen is the mandible is really too small to do that kind of procedure. The bone plates would be too big and whole of the mandible would be just on the bone plates itself. So those bone plates can lead to fracture again. Now hence we cannot do such kind of surgery in these kind of cases. So what do we prefer here is we prefer to do distraction. A big importance point is that the distraction can be done even before growth cessation. So if I want to do distraction in this patient at this age, yes, I can do that. If I want to do surgery, no, I have to wait till the growth has completed. So the patient has to live like this for about 18 to 20 years till the growth cessation. So this has a lot of psychological impact on the patient. Hence distraction has a benefit that it can be done at any age whatsoever, and next thing is it can lead to growth of the bone. So what we will do here is we'll put a distraction device and we'll increase the length of the bone. So we'll increase the length of the callus and then that will ossify to increase the length of the bone. So we will have a natural bone of increased length. So in cases where we have very small mandible or very small jaws, we always try to go for distraction rather than orthognathic surgery. Why? Because first of all it can be done before growth cessation at any age, and second thing is we can grow bone with the help of this appliance. So this appliance was of distraction osteogenesis. Let's move on to the next. Now the question which is asked from this picture is, what is the disease the patient is suffering from? Now let's see the clinical feature which are here. You can see the hair, they are very less. Then if we can see on the OPG, there are multiple missing teeth. A lot of teeth are missing. As you can see here, whole of this segment is missing. This is a canine which we have. The interior segment is missing. Here also the interior segment is defective. We have very few of teeth. So this is a classical presentation of ectodermal dysplasia. Now here we can see a child with ectodermal dysplasia in addition to the characteristic thin and light colored hair. Here is thin, very less hair, sparse hair. So what we can see is the panoramic radiograph shows multiple missing teeth. So when this number of missing teeth are seen, we always suspect ectodermal dysplasia. So what lesions are seen here is that there is defect in the ectoderm formation, and as we can know that the teeth are derived from neuroectoderm, and hence there is a large number of teeth that are missing. So whenever this number of teeth are missing, we always suspect it to be ectodermal dysplasia. Okay, so moving on to the next. So the question which is asked from this picture is that what disease or what condition is being shown here. It's a classical presentation of that condition. So let's see what we can see here is the tongue. It is contracting the interior segment. The interior segment is much ahead of the tongue. The overbite is increased. Overbite and overjet are increased. So this is a classical presentation of a tongue thrust swallow. So this is a typical appearance of tongue thrust swallow with lip pulled back. Note the tongue tip between the incisors protruding forward toward contact with the elevated lower lip. So what we can see here is that during swallowing, the tongue, it is contacting the lower interiors. In a normal swallow, what happens is when we are swallowing, the tongue contracts the interior palate in the rugae area. But during this tongue thrust swallow, what happens is instead of the rugae area, the tongue comes forward and contacts the lower incisors. Now what will happen due to this is the tongue will start pushing the lower incisor ahead, due to which there will be spacing in the lower incisor and also in the upper incisors. So we also ask that what is the classical sign of tongue thrust swallow? It is always increase in spaces. See, the patient will come to us and he will say that I have to get my spaces corrected, that I have spacing in my teeth, I want to get it corrected. The next question should be, are the spaces increasing? Why? Because tongue thrusting is a constant phenomena. The tongue is going to put constant force on the incisors. So what will happen is that the space will go on increasing. So whenever the patient says yes, the space that I had is increasing, then we can suspect that there is tongue thrusting. So this is a typical picture of tongue thrust swallow. So moving on to the next slide. So the question which is asked from this image is that what measurement is being done in this picture, that what are we measuring. So let's see what is the answer. So what we are measuring is simply we are measuring bizygomatic width. It is used for facial index. Now what we do in facial index is we measure the bizygomatic width as well as the height of the face or the facial length. Now these two measurements are done to get the facial index. So here we are using, this is anthropometer. Now this is used to measure the, here we can see this is the most prominent part of the zygomatic bone, and this gives us the bizygomatic width. So this is how bizygomatic width is measured. So moving on to the next. Now this is a typical image that signifies a problem. Now we have to identify that what is a dental one and which is a skeletal one. So here what we can see is In both the images, here we can see that there is presence of crossbite. We have to identify which is the dental one and which is the skeletal one. So let's see. So the posterior crossbite, it can be dental as in a patient with adequate palatal width, that is the distance AB is approximately equal to the distance CD. Now if you can see here, this kind of crossbite is dental crossbite. If you can see the teeth, they are palatally inclined. So here the distance AB is approximately equal to the distance CD, hence the skeletal problem is not there, what we have is only dental problem. Now why it is important is because we have to correct this problem. So if we only have the dental problem, what we need to correct is the dentation only. We need to put an appliance which will lead to the expansion of teeth only, so that we can correct the crossbite. But in this image what we can see is AB is very small as compared to CD. So here it is a skeletal crossbite. So also the teeth, they are in good alignment. So in this case, if I just expand the teeth, what will happen is the it will tip the teeth in a buccal direction. So we will have an abnormal inclination of the teeth. So along with the teeth, what we need to expand is the skeletal bone. So we need to expand the palatal bone also, due to which this is a skeletal kind of crossbite and this is a dental kind of crossbite. That was all in this part of image based question, and thank you all for your time. Thank you.